glad you were able to get up on a Sunday morning to attend boring talks like ours. But I will try to make it fun, and mine is a pediatric portion of scoring sleep, so it's going to be a little, most of it is going to be same, but there will be some differences also. So, what did I do here? All right. So, we're just going to touch on sleep maturity, the sleep requirement, and pediatric sleep, a little bit on pediatric sleep scoring, and briefly identifying events, respiratory events in sleep. So we're going to start with the fact that pediatrics includes from birth to 18 years of age. Having said that, there is a wide range, there is commonalities, but that's the only lowest common denominator. But in reality, there are a lot of variances which you have to include, expose yourself to over a period of time to understand. Infants in this age group generally sleep like, the infant recommendation is that they sleep almost 14 to 17 hours, which include naps. And then newborns have no specific time, so they just get up and sleep whenever they feel like, want to, I guess. So now the infant scoring is for 0 to 2 months post-term, and full-term kids also, after post-term, 37 to 42 gestational age also is called infants, and 1 to 12 months of age are considered infants. Now, the beauty about them is that they are circadianly developing the circadian rhythms. So you are going to see a change as they grow over the first 1 year. It grows on, circadian rhythm timing undergoes major developmental changes in the first few months after birth, and all of us who are parents have experienced that. And from at about 1 month of age, the core body temperature also begins to emerge. So this is when you're starting to see the child grow and develop. By 2 months of age, infants will start sleeping more at night and less during the day. And by 3 months, the androgynous production of circadian-driven hormones like melatonin and cortisol will start getting produced. So important again for these little babies to have good quality and quantity of sleep. Now, infant scoring, it's a little different from children's scoring. So what would we score in an infant? You score wake, you score non-REM, which is just stage 2, and REM sleep. Now there is another fourth portion which is called transitional, which is intermediary, which means if I cannot put it as more than 15 seconds of wake or stage 2 or REM, that's when I'm going to call it as a transitional stage of sleep. Not all sleep softwares accommodate for that. However, I think Somnomedics, if I'm correct, does accommodate for transitional sleep, right? Yeah. So the newer softwares are accommodating for infant sleep staging also. So, for example, if the epic contains 3 it's non-REM 3 and it's got a little bit of 2, then you're going to call it, stage 2. And so, generally, like, you're going to see what is dominant. Based on that, you are going to call the epic. Let's move on. What does it look physically? Physically, when the child is sleeping, the eyes are going to be closed. There's going to be decreased movement, regular inspiration. Trace alternate is another form of waves that you see only in infants. And then there are high voltage and slow voltage waves. And they're rudimentary sleep spindles. So when they're born, they don't even have sleep spindles. So it's the growth that you see over the 1 year. So it's important. Then eyes are closed, and there's you don't see, in non-REM you don't see any eye movements. So very typical of even say older sleep patterns. And then chin EMG is present sometimes, but it could come down because a lot of these kids are suckling, and you're going to see all those kind of movements also. Sorry, I think I've got it. Okay. So like by 38 weeks, you can, REM will appear same as wake, which is continuous and polyfrequency waveforms. It is called active sleep. And in the first year, you're going to see wake to REM transitions very commonly. So, because the child will just go into REM immediately as soon as they go to sleep. And REM at birth is almost 30 to 50%, while in the adults, REM is typically between 18 to 25% max. And then the REM non-REM cycle also is shorter in pediatric or infant population, wherein it's only 60 minutes. And while Pankaj was talking about the adults, it's between 90 to 110 minutes. So now this is another area that is important when we are scoring a pediatric patient, which is to learn to pick up what's called occipital or posterior dominant rhythm. Now what you see, how you see that is you typically look for the occipital region in the brain. From a 30-second epoch, you come down to a 10-second epoch, like an EEG, and then you choose a particular section, and in the occipital region, of the brain. Hang on. So it has to be 1 second, and you start counting. And that occipital dominant rhythm or posterior dominant rhythm, it increases with age. So between 4 to 5, by the time the child is 6 months, you're going to see 4 to 5 alpha waveforms in 1 second. By the time they're 1 year, about 6. By the time they're 2, you see about 7. By the time they're 3, 8, and 8, you see 9. And by the time they're 10, they should have an occipital dominant rhythm of 10. After that, you're going to see anywhere between 10 to 14 as an adult. And then, of course, the same slide, I just wanted to reinforce again. So by the time they are 15, it's 10 and all the way up to 14 hertz sometimes I've seen. How do I count it? This is how I count it. I count it either if I go from peak to peak or crest to crest, it's going to be 10 either which way. So if I'm going to be counting, so if I'm going to count the crest 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10, and it's going to be the same when I do it on the top. So you can see posterior dominant rhythm of a 10-year-old is definitely bigger than that of a younger child. And there you see. So there you go. This is for a 2-year-old, and that's how you're going to find. And for a 13-year-old, you see it's a little bit more compressed and tighter. And this you pick up when the child is, comfortable sleeping with eyes closed. So for each child, the way you run the study is that you do the biocalibration and give them 5 minutes, which we call as parameters, wherein you allow the child to rest and calm down and stay with eyes closed. That is the time you pick up the occipital. Sometimes it's not possible, and when it's not possible and the child is distressed, at that point you wait for the closest epoch where you see the child going to sleep. So the epoch before that, you try to pick it up. Or again in the morning when you're doing the biocalibrations, you can pick up. So you have 3 options there. So now children have what's also called trace alternate. These are infants, and you can see there's bursts of activities that come in, which are followed by parallel low activity, as you can see here. And these are called the trace alternates, and you only see them in infants, and as they get older, you're going to see that they drop off. Again, in this you can see the mixed frequency sharp waves, but there's there's sudden bursts that you can see in the activity. So here again, now infants are scoring quiet sleep and active sleep in the newer softwares instead of non-REM and REM. So this is quiet sleep. Quiet sleep is non-REM sleep, and REM sleep is what we call active sleep, because that's when there's a lot of body twitches, body movements, and involuntary body movements. And then of course we did discuss the transitional stages of sleep. Now ASM of course mandates that we score our stages at 30 seconds, and these are between 1 to 18 years of age. You do non-REM and REM. And the wave backgrounds, I'm just going to go over very fast because Pankaj has already gone through it. So the alpha waves and theta waves, these are the numbers that you can see them in. And here, this is in the younger children up until the age of 12 that you see hypersynchronous activity. These are called hypnagogic hypersynchronous bursts of activity, which is absolutely normal. And by the time a child is about 12 years, they start fading. So they typically happen in early stage 2s, and towards the end of the night, you don't see them as often. And in pediatric population, again, stage wake is when eyes are blinking. The technologist here is mentioning that the patient is awake. So notes for your technologist are extremely important. You need to train your tech to be able to write good notes so that you can interpret in the morning much better. A lot of times I see they don't, and that's where I think you as a physician need to impress upon the need and insist upon that. So you see the nasal pressure cannula is also a little bit louder, and then that's the abdominal belt, and the movements you can see. And here chin is elevated in a real time, and you can see that eyes are moving back and forth. They're scanning. And a 3-month child's wake and a 3-year-old child wake is slightly different, as you can see from these two slides. And as they get older, you can start seeing that alpha comes in older kids, and the green section of the arrow is where there's a slight amount of what we call micro sleep, but it doesn't quantify enough for me to call it stage 1. So I'm going to still continue calling it wake. Now here we are wake for a 16-year-old female, and you can see a lot of alpha, a lot of eye movement. And next is we're going to look at alpha that has been talked so much about. In my mind, alpha looks like blades of grass when you look at. And the blades of grass, the more blades of grass that you see, that's when you can start counting it as alpha. There you go. And now to stage 1. So it's a transitional phase, which is from transitioning from sleep to, from wake to stage 1, or 2, 1, yeah. And it lasts about 5 to 10 seconds, I'll just go on fast here. So you can see the slow rolling eye movements and alpha in the sleep stage 1. And then as we go, you again see slow rolling eye movements, and that's the vertex sharp wave. And the chin tone is becoming more even. And then in stage 1, if I see mixed frequency waves, I'm going to go and count exactly. So in this, I was able to pick up wherever I find sleep, and I was able to get 16 seconds of sleep. So I went ahead and called it stage 1. Again, non-REM, stage 1. And that's rhythmic theta waves in stage 1. with the, we kept talking about multi-frequency waves, mixed frequency waves. That's what you can see in stage 1 in children also. And this is another hypersynchronous activity wave. And Pankaj mentioned about sleep spindles, so let's quickly look at pediatric sleep spindles, which are really big and very prominent. And that's the K complex. So to me, the spindles look like leaves, making it more simplistic and easier to learn. And the pointed version is the sleep spindle, again, you see. But in children, you can get confused with delta waves because the waveforms are really huge. And a lot of times the children just go into stage 3 and it's a long, almost 50% when they are having their growth phase. So if a child is in stage 3 and not waking up, you know that they're in deep sleep and they're going through a growth phase, and you want to allow them to go through that growth phase instead of just waking them up. And in the spindles, you can see that how the left side picks up spindles faster than the, the other way around. The right side, my bad, left side picks up and then it's followed by C4. So again, it's non-REM 2. And then when we go to stage 3, you cannot miss a pediatric stage 3. It is impossible because it's going to be in your face. And in my head, again, this looks like tents, American Indian tents. And they're called the teepees. And the chin AMG is stable. And this is the most stable phase of your sleep because the body can readjust, align itself to keep the airway open. And so you have real beautiful waveforms. And I'm just going to go fast. Now, slow wave begins to decrease at puberty, and as we get to our age, I think we start craving for that. And all of us need slow wave. If there is a pill somebody can make for slow wave sleep, I think we'll all be rich, whoever makes it. So there you go, some more slow wave. And this is non-REM for a 3-month-old. And don't miss the chin in green. We'll come back to it. And this is for a 3-year-old. And REM sleep is, so what do I see? There are 2 types of REM, tonic and phasic, even in kids. So those are all the options that you have, like low frequency, irregular mixed frequency waves. You can see 1 or more REM cycles. And so this is what it looks like. You see sawtooth waves in a beautifully acquired study, perfect sawtooth waves. Then you see drop in chin tone, and you see the conjugated eye movements. This is very, very typical and very, very beautiful REM that you can find in a normal child. And again, here you can see the child has got conjugate eye movements, drop in chin tone, and the sawtooth waves. And 3-month-old REM versus a 3-year-old REM here. Now, this is a slide which I would want some feedback from any one of you. Does any one of you know what's happening in this slide? I mean, it was scored N2. Any idea what's happening here? So the child was suckling. It's an infant, so the suckling movement you can see in the chin tone in the green, where there is rhythmic suckling happening. So now let's take a quick look at the differences in the central, mixed, and obstructive apneas. I'm going to go over all this very fast. That's a normal airflow. In central apneas, like Pankaj was mentioning earlier, there's no effort complete in any of the leads. And in mixed, you're going to see effort, no effort initially, and then you're going to see some movement in the belts, and then finally you see movement in the nasal cannula and thermistor. And this is, you see effort in the belts, and it's only the airflow that is completely flat, 90%. So So these are the respiratory events. So let's look at the centrals. Primarily, I'm starting with centrals because with pediatric population or adults, it is called, when I went to Atlanta School of Sleep Medicine for my pediatric training, they I guess highlighted this over and over again, that it's a 2-breath rule from birth to death. The 2 breaths of a newborn versus a 2 breaths of a 90-year-old or a 50-year-old or a 40-year-old or a 30-year-old. So in every biocalibration, you have to pick up the respiratory rate, you want to pick up the ODR for all children, and you want to pick up the heart rates. These are what are going to help you when you come to picking up events. So in this scenario, the central apnea is only acceptable for pediatric population if it is 20 seconds in length, which is a long time for a baby not to be able to breathe and hold the breath. That is concerning. Or you can call a central apnea if you see 2 breaths with an arousal or 2 breaths with a desaturation. Those are the only times. You cannot say 10% and it's a central event like you do in an adult. So that's the biggest difference that you have to see. The other thing is that any, whether it is hypopnea, apnea, it's again a 2-breath rule. If you cannot pick up the 2 breaths and the length of the 2 breaths, it could be 5 seconds for a newborn infant, it could be 8 seconds for a 1-year-old. So every child, you have to identify in the biocalibrations the 2 breaths, the length of the 2 breaths, and follow it through for the rest of the study. So always, 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 you need 3 things. One is respiratory rate, the other is your heart rate, and the third is your occipital dominant rhythm or posterior dominant rhythm. Because that tells you whether the child is cognitively where the child needs to be. Sometimes there can be a regression, that you see somebody who was 14 and during your last study has come down to 10 or 8. Then you know there's something happening and the child needs more attention medically. So that's why every time a child comes to the lab, you have to get that occipital dominant rhythm. The other thing that I want to stress is for pediatric population, it's not just one and done kind of a study. Once you identify a child with some kind of apnea, you need to get them back every year to monitor them, because the tendency is they could fall back. The first line of golden standard of defense is adenoidectomy, tonsillectomy, and TNA, okay, tonsils, adenoids. And then after you've done that, you bring the child back 6 to 8 weeks later for another sleep study to confirm if there is any residual apnea. If there is no residual apnea, you monitor the child every year, because chances are that it could reoccur, you may have other issues. Most syndromic children that come to you will definitely have some sort of issues with their breathing pattern and sleep. So they definitely would need, and 2% of pediatric population are children with special needs across the globe. So we know that 2% in India is a very, very large amount. And all of them probably need it. 1, because they can sleep better. 2, because you're improving the quality of life index for the family and parents and the siblings. So that's why it's important that you help them out as best and as early as you can. So here you see that. I went a little bit ahead of myself, so I'm just going to go fast. Now this is the mixed apnea that we were talking about, and obstructive apnea. And this is real-time hypopneas and apneas, and you can see when it comes to obstructive apnea, it can be a standalone. It need not have arousal, or it can have it, but it need not have for sure and a desaturation or an arousal. For hypopnea, however, you need to have both or either or. either a desaturation or a arousal. So there you go. And I wanted to show you this. Here was a child who was about 8 years of age, came to our lab, and in the first third of the night, this poor baby was like desatting crazy. The need for EtCO2, as you can see, 120 to 50, that section is the EtCO2. It was going over the roof there. And this is called the first third of the night where we saw. And then the tech went back and called the physician to start an emergency split night because we can't send the child home desatting that low. So look at this child. The child desatted to 47. Imagine a child, what would you expect your child to do in school? What would you expect your child to retain? You know, cognition, everything gets affected with it. And so immediately the technologists were smart enough to call the doctor. Doctor said, go ahead with the split night protocol. They started the child on PAP, and look at that beauty. The PAP, he went up to 13, and this is the REM on PAP of 13. The child was comfortable. You can see heart rate was stable. The CO2, which is 45, was stable, and oxygen saturations were fine. And I mean, of course, he went into REM rebound, but it's just something that, you know, this picture speaks 1,000 words to me. And in summary, I just want to add that children sleep for greater periods of time, so their problems carry greater weightage. So that's one thing that we have to remember. Difference in sleep architecture for pediatric population is the reason why, you know, scoring rules are slightly different, and it's important for us to immerse ourselves in that before we can come up victorious and share. And consequences of sleep disordered breathing in pediatric population could have long-term serious health effects, and we all as healthcare providers, I think we need to remember and understand and see how best we can help our, you know, next gen, which I think is going to be leading rest of the world very, very soon. They've started, and I guess rest is happening. So with that, I'm going to end my slides, and thank you for your attention. If you have any questions, let me know. Thank you.